So the case is, and that's actually a story of a young lady, 15 years old. She was abandoned by her mother, and she came first with an acute presentation of a Wilson disease, acute liver failure, in a very bad situation and very bad condition, medical condition, with already acute renal failure. She was also very severely injured from the point of view of the liver. We found her mother, and she came to donate liver to her daughter, so that was a nice part of the thing. We started CytoSorb, and we continued it during the liver transplantation. That went great, and so she recovered after liver transplantation.
We had one case in our hospital which was completely different from all other therapies we had before. Was a woman, she fainted a couple of times at home, and as she came to admission at our ICU, we saw a patient developing multi-organ failure under cardiogenic shock. We decided for a CRRT and to use a CytoSorb filter with this, and she was, as we thought, nearly dead. And what we saw in the therapy within the first 24 hours was a tremendous decrease of lactate and all enzymes. We could manage 3 filters, so for 72 hours, and after this time liver enzymes were not normalized but nearly normal, and after 6 days we could end ventilatory therapy.
I report a 51-year-old lady that has been admitted to our intensive care unit due to ingestion of suicidal doses of imipramine and quetiapine. She developed a severe arrhythmia despite all efforts to try to keep her out. We weren't able to cope with the electrical disorder in her heart, and therefore decided to put her on cytokine removal therapy. So she received hemofiltration and cytokine absorption during resuscitation, and we managed to get her stable within a 2 hours course.
So far I have treated 41 patients, all in the acute phase of septic shock. One of those is, I believe he was 72 years old, was operated because esophageal cancer. Later he developed a subphrenic abscess on the left side. So I asked the surgeon to drain the abscess, which he did. So I bolused him with adrenaline, 1 milligram. That helped for about 2 minutes, bolused again. Quickly put in the catheter, and within 1 hour he was hugely hypertensive. We could stop the adrenaline shots, and we could reduce the amount of dopamine, and he was off the inotropes within 24 hours. It's clear he would normally have died in the acute phase. We saved his life. He left the ICU, he left the hospital, and that was a twofold message for me. Even in the hopeless cases, you can use it.
I think one of the most dramatic events and case what we treated was a young lady who fell out from her bedroom and suffered multiple trauma injuries. Then we noticed that her renal function was deteriorating, and we also measured extremely high cytokine and procalcitonin levels. There were obvious signs of a cytokine storm, so we decided to treat this woman with CytoSorbent. So then she required a few treatments for acute renal failure, but then she made a full recovery, fortunately.
The most interesting experience that I've had by using CytoSorb has indeed been the one related to a patient that we have surgically operated in order to transplant his liver with one from a donor who had his heart stopped. Unfortunately, the liver did not start to work after the transplant. Its function gradually and quickly deteriorated to the point of implicating what we call primary non-function. Therefore, the patient later received another transplant with a new organ. Yet after this second transplant, the patient's condition was very critical. At this stage, we decided to treat the patient with CytoSorb. We have actually treated the patient with 4 successive CytoSorb cartridges for a total of 120 hours. During the next days, the situation continued to improve increasingly, bringing the liver back to normal levels. Now the patient is back home and in good health.
Our experience with the CytoSorb is that these patients, after the filtration, have a quicker recovery, a lower use of catecholamine therapies, a lower incidence of infections, and a significant reduction in deep sternal wound infection.
The use of cytokine elimination in that patient has given us time to play with, and I'm pretty sure that she wouldn't have come out that easily, and we would have probably looked at much more morbidity and organ dysfunction without using the filter in this specific case.
I can't say from this one experience that this therapy can save every life and work this way every time. Though I have never seen before an extracorporeal therapy reaching such a brilliant result in such a short time.
We think without this therapy, maybe she would have died under our hands, because it was our, as we would say, single option we had when we took it.